Here a case of 70-year-old patient. This patient is deaf and schizophrenic. Patient who presented with a drop of vision in both eyes long time ago. His vision was light perception in both eyes. You can see the density of this cataract in the slit lamp. It's a Morganian cataract. Morganian cataract is a hypermature cataract, whereas the dense nucleus sink posteriorly in the liquefied cortex. This patient has a history of tracheostomy, so the general anesthesia was not suitable for this patient, and this surgery was done under local anesthesia. You can see now the pupil is about 4 millimeters in maximum dilatation, and you can see the calcium deposits in this anterior capsule. After staining the capsule with the trypanid blue, dispersive OVD was used to protect the endothelium of the cornea and to viscodilate the pupil, as you see. Now starting the rhexis with the double rhexis technique. The first small rhexis, you can see now the liquefied cortex comes out from this small rhexis. Aspiration of the liquefied cortex with 23 gauge cannula. Now you can see the dense nucleus, as you see. Now the aspiration, this is the dense nucleus of this hypermature Morganian cataract. Then enlarging the nucleus using the double rhexis technique, as I said. You can see using the rhexis forceps to enlarge the capsular rhexis. This is the double rhexis technique, doing small rhexis first, then aspiration, then continue enlarging this rhexis by doing the second large rhexis about 4.5 to 5 millimeters. You can see how dense is this cataract. As there is phacodonesis and the zonule are weak, so I used the capsular hooks at 4 opposite points to fix the anterior capsule. As you see, this is the first capsular hook fixing the capsule at this point, fixing the anterior rhexis. You can see it. Also, I fix at the other point using the capsular hook. In this side also, and at the opposite side. You can see now the pupil, it's small, about 4 millimeters in the diameter. The challenges in Morganian cataract are the high risk for peripheral extension during doing the rhexis, which is Argentinian flag, and rarely it may associated with posterior capsular opening without history of a trauma. Now you can see the pupil about 5 millimeters. You can see the rhexis is fixed well with the capsular hook. You can see the density of this cataract, starting the phacoemulsification using the horizontal chop technique. It is important while removing this dense cataract to inject the dispersive OVD all the time of the surgery to protect the endothelium of the cornea. Here the horizontal chop technique, as you see, chopping this dense cataract to smaller pieces, then emulsifying this dense cataract. But as this patient is under local anesthesia and the patient is deaf, he was uncooperative and he was moving his head all the time of the surgery. You can see now while I am inside the AC and starting to emulsifying this dense cataract, you can see how this patient is moving his head suddenly. You see now, it's a dangerous movement. I was lucky that I don't damage the posterior capsule and that I pull my hands quickly from the AC, then also re-inject dispersive OVD again, as you see, and you see the movement of the head of this patient. It was difficult to communicate with this patient. Then I tried to continue chopping this dense cataract as fast as I can and increasing the power to emulsify this dense cataract. The main problem here, as you can see, the posterior capsule is floating all the time of the surgery. Some surgeons prefer to use intralenticular IOL scaffold technique, which can protect the posterior capsule from inadvertent rent during emulsifying this cataract, and also it can inflation of the capsular bag. You can see here the weakness of the zonule. So I inject again OVD to forming the capsular bag and to keep these last two pieces in the anterior chamber. Then continue emulsifying these dense pieces, as you see. After removing this is dense cataract, you can see now also how the posterior capsule come anteriorly. Now injecting the OVD to insert the CTR, capsular retention ring. I prefer to use the zonule friendly technique while inserting the CTR by holding the eyelet of the CTR by the secondary instrument and inserting the CTR, then free the eyelet by the end of the insertion, then removing the capsular hook, as you see, preparing to implant the IOL. I implanted in this case 3 pieces IOL with the haptics in the sulcus, and with the optic is capturing the anterior rexes. As you see now, implanting 3 pieces. You can see the haptics in the sulcus. Now adjusting the haptics inside the sulcus, then doing centration of the optic. After that, you can see now I capturing the optic in the rexes. Here the optic is capturing the rexes. Now you can see the optic is capturing the anterior capsular rexes, then washing the OVD, as you see, from the anterior chamber to prevent spike of eye pressure by the end of the surgery or during the follow-up. Then stromal hydration of the wound. You can see how this cataract is dense, and you can see how the surgery is difficult. It was hard and tough surgery, as this patient moving his head all the time of the surgery. Thank you for watching.